And good evening, everyone. Welcome to the Oculus Clinical Webinar Series. Tonight, how the Pentacam scan quality affects patient outcomes. Thank you, everyone, for joining tonight. I want to remind people a little bit of housekeeping. Any questions you have, please put them in the chat, and we're going to leave time at the end to answer your questions. Tonight, our speakers are myself, Dr. Bill Tullo, Medical Director at Oculus Inc., and Michelle. Introduce yourself.
Hi, I'm Michelle Stoecklin. I've been on the clinical applications team going on 5 years now, so I'll be speaking in the beginning portion about quality of scan, and Dr. Tullo is going to be going at the end on how quality of scan can affect your data and your outcomes with your patients. So,
All
thank
right,
you.
Michelle, take it away.
All right. All right. So to really understand what affects scan quality, you really do need to understand how the Pentacam technology works. And the Pentacam is an anterior segment tomographer. It utilizes a rotating Scheimpflug camera, which is located here, and that rotates 360 degrees, covering the cornea. And in the lower left, what you're seeing is those raw Scheimpflug images. And these images are really important for the quality of the scans. And a lot of the troubleshooting that comes from this comes from these live windows during the scan capture. You can see we have the front-facing iris camera and our live Scheimpflug image. Now, those raw Scheimpflug images, the software does an edge detection of each of those surfaces, the front cornea, the back cornea, the iris, and the lens. This is how we get our radius of curvature measurements, our anterior chamber data, our pachymetry measurements, is because of those images. The standard Pentacam has 25 Scheimpflug images that is taken, and an edge detection is done to each of those surfaces in those Scheimpflug images. Now, since the patient is in primary gaze, everything is stitched around the visual axes, giving us a 3D model of the eye. We want good raw data. When we take poor quality scans, garbage data in equals garbage data out. Now, what can be affected by poor quality scans is contact lens design, refractive screening, cataract screening, densitometry, IOL calculations, and more. And this is the portion that Dr. Tullo will be reviewing, is how these poor quality scans can be affected and what data can be affected from that. Now, to understand what can go wrong, it's important to understand how scan capture takes place and the troubleshooting points you can do throughout that. The biggest thing we can make sure is that the room environment is correct. The Pentacam scans need to be taken in a dark room. We can, like I said earlier, I do use these two live windows as my quality checkpoints. So the lower left live Scheimpflug window, I want it to look like the image on the right. The image on the left is an example if I left those overhead lights on, and you can see a reflection of that cornea on the live Scheimpflug image. You could imagine that the edge detection software isn't going to work properly for this. Another point is the fact that the patient should understand what they're looking at. So they're going to be looking at a circle in the center of that blue slit beam, but it's also to explain to them that that blue light's going to rotate. So a lot of the time when you're working with a patient, they might, when you initially start that scan, the light rotates and they're surprised by that. So that first scan can be used as a trial run for this, for the patient. So then you're able to then go back, retake the scan, and have a good quality scan the second time round. So because the patient understands what they're looking at and the fact that it's going to rotate. These are my quality assurance routine. This is the sequence in which I do it. So step one is check your live scan windows for coverage, check your Scheimpflug images, check your horizontal white to white, and that is derived from your iris image, check your quality specification, and check your scan coverage. So these are all points that I go through during the scan process and after. And I'll be reviewing each of these checkpoints. I'm going to show you how quick that process can be when everything goes right. So we're going to watch this video. I've selected my patient, I've launched the Pentacam software, and I'm going to go to examination and scan. We're going to default to the standard Pentacam scan, the 25-1 Scheimpflug imaging. And once again, I'm going to use these two live windows as my quality checkpoint. Am I seeing the coverage I want here? Am I in the correct room environment? Patient is fixating on that target. Once I'm in position, it'll automatically capture, which is what you're seeing here. I'm going to check my Scheimpflug images as they load. These look good. I'm going to check my iris image. It looks good. And then I'm going to check my quality specification. I'm going to check my coverage. I can see that I got a horizontal white-to-white measurement because my patient did not blink. That is the process. That is how fast it can be. So it is a very quick check. Once again, check your live scan windows for coverage. What you see is what you get during that capture. So I'm going to make sure before I'm in that final position, I'm going to have the patient blink, open their eyes as wide as they can, so I get as much corneal coverage as I can. I'm going to check artifacts in the Scheimpflug images. In the example on top, we are seeing those frames being blocked, or those live Scheimpflug images being blocked because the patient blinked. So we retook the scan, and on the second attempt, we have much better quality scan for this patient. The third thing we're going to check is our horizontal white-to-white. Once again, it is derived from that iris image that we can see in the top left up here. And we're going to zoom in. You can see the horizontal white-to-white measurement right here. If my patient blinked, like in this example, we can see there's no iris image, and then there's no horizontal white-to-white measurement. The next thing is checking your quality specification. And I'm going to go ahead and zoom in here. In the field right here, where it says QS, standing for quality specification, you can see it says white OK. That is the best you can get with your Scheimpflug imaging. And if it says anything other than OK, it'll show up in yellow and red. If it does show up in yellow and red, the scan quality is not within acceptable limits. The big thing here is, what is it saying? What does that QS field say? So I can, once again, left click in this field, this text box will appear, and I can click on these little yellow triangles, and more text boxes will appear, which I'll show you in the next slide. But once again, is it showing up in yellow or red? What's causing that QS error? Can I troubleshoot it? And that's what these yellow triangles can help with, is that text box that appears and describes the error and how to possibly alleviate it. So understanding what those errors are is really important with quality specification. I just had talked about the fact, what's causing those QS errors? Is it irregular corneas? Are they opaque corneas? Is it everything else? Is it the room environment? Is it mass patient discomfort or facial anatomy that's getting in the way of the Scheimpflug images that's causing disruption to edge detection? What's causing the QS? And that's the biggest thing that we can do, is when we do run into those QS errors that show up in yellow and red, is it an error that we can alleviate? Can we fix it? You saw how fast that scan process is. There's no reason when we see a yellow or red QS that we can't go back and retake it very quickly. Here's some examples of some errors that we've run into. On the top, we can see those two solid black frames. So we have blinking error, lost segments. That is something I can fix. On the next example, I do want to make note on the top one, please notice the alignment of the cornea here versus here. We have an XYZ alignment error. So the patient sat back during the scan. The other thing is, you can see data gaps. You can see gaps in the data here due to this white source, which is actually a light source in the room that's causing disruption to the edge detection software. That is where the data gaps are arising. These are all things I can fix. I can get my patient in the correct position. I can either put a drape over the patient, or I can get that light source to be turned off. These are things I can fix. This is another good example. Patient blinked, they moved, but we have errors, blinking error, data gaps, lost segments, and so forth. But look at the 3D model that was rendered. This isn't accurate, but these are things that I can fix. I can prepare my patient more, I can get them positioned correctly, I can have them blink, open their eyes wide as they can. These are things, once again, I can fix. I can't fix irregular corneas. That is not something I can fix. I can't fix opaque corneas. So when you run into patients with irregular corneas, it's understanding, is that what's causing the QS? Yes. Retake the scan. Retake the scan a few times. Make sure the data is reproducible. That's the biggest thing we can do. Retake the scan, make sure the data is reproducible. And also, the fourth point I'm going to be getting to now, did you get the coverage that you needed on that irregular cornea? That's the next thing. check your scan coverage. Make sure you have good coverage, because this is what the doctor is going to be using to make decisions, either for contact lens fitting, cataract screening, refractive screening, it doesn't matter. The quality data that you get with the Pentacam also is the coverage. We want to make sure that we have as much coverage as possible, because as you can see in this core 8mm map, it's saying lid error, and I can see the coverage down here in that core 8mm map once again is lacking because of the lid getting in the way. The Pentacam can capture up to 11, 12 millimeters of corneal coverage. There's really no excuse that that 8mm circle isn't full of true data because of the fact that the Pentacam can capture as much data as it does. Depending on how your software is set up, it can either show up as either white section or black dots. It's the same data. It's just how you've chosen the data to be represented. The big thing is we want as much true data as possible in that core 8mm map. I want my scans to look like this. It needs to be 8 millimeters of coverage, and Dr. Tullo will be going over this on how the data can be affected by having lack of coverage. The Bell and Ambrosio display does need 8 millimeters of coverage. If it shows up less than 8, it'll show up in yellow. Anything less than 7.5 will show up in red. But the big thing here is make sure you have enough coverage. The other point on this display that I don't have highlighted, but is choose your correct reference database as well. Make sure myopic normal or hyperopic mixed is selected depending on the patient's refraction. Myopic normal is the default. If the patient's hyperopic or mixed still, then you would select that. Okay. Making sure the patient is also positioned correctly in the headrest, but also that they're fixating properly is another really important point. So we want to make sure that they're aligned properly during the scans, because that can change corneal shape representation. It can change quite a few things. So we want to make sure that the patient's fixating properly and that they're properly positioned in the headrest as well. And that's what you can see here is the patient's positioned correctly. You can see there's much more drastic tilt to that iris just because of the misalignment. The Pentacam has high precision and reproducibility between scans when using automatic release, because it's not the technician deciding when it's in position, it's the device deciding when it's in position. But there are scenarios when we deal with irregular corneas that manual capture needs to be done because automatic release was unable to due to the irregularity of that cornea. And this is just an example on this slide. Same patient, same day, 2 manual scans. There is some slight variation in this data, but a severely irregular cornea. And we want to make sure take multiple scans if you take manual scans, but it's the same rule of thumb. If you have yellow or red QSs, take multiple scans, make sure the data is reproducible. Okay, the quality specification for a technician versus the doctor is going to be slightly different. The patient or the technician is going to perform the scan, check quality specification, check for 8 millimeters of coverage on the Bell and Ambrosio display. They need to make sure that they also select the appropriate reference database for the Bell and Ambrosio display, and then they're going to print export those displays for the doctors. I am going to put a disclaimer here. If a mistake is made, the wrong reference database is selected, you can go back and redo it. It's not a one and done. You can go back and redo it if you need to. The doctors is going to be a lot more verification. They still need to check their QSs. They're going to make sure that they got the coverage they needed on their displays. They're going to confirm the appropriate reference database was selected. They're going to compare the left and right eye simultaneously with each other. And if anything in this list seems abnormal, they might need to go back to the Pentacam software and investigate further into other displays, like reviewing the shine fluke images, seeing what was happening with that edge detection software, and approach it in that way. So that's the end of my presentation, and now Dr. Tullo is going to take over.
Thank you, Michelle. Great job. So it's important to know that the quality of the reproducibility and the sensitivity of the Pentacam is determined by the quality of the scans, and that's why looking at the QS values is so important. It's also important to understand that the QS values in different displays have different meanings. So it is possible to have normal QS on one display, but abnormal in another display. So let's look at some examples. Here's an example of a 4-map refractive, and there are 2 QS values in the 4-map refractive, one for the front of the cornea and another for the back of the cornea. And you can see in this example, both are red, so these should be repeated. These are not examples that should be downloaded or printed or exported to EMR. We should be able to get better scans on this on most eyes. Now here's the BAD display, and the quality specification for the BAD display is a single quality display. You can see this example is white and normal. Everything is okay. But again, this could be yellow or red, while the 4-map refractive is white. So it's important that we look at both of these displays. If we're going to utilize a display, it's good to really scrutinize the QS value on the particular display you're utilizing. Also, with the BAD map, in addition to the QS value, it's important to look at the capture diameter. You can see the arrows here pointing to the front and back capture diameter of 8 millimeters, and there's no red or yellow flags here, but if the capture diameter was reduced, it would flag red and yellow for you. And we have some examples of what that looks like. Here's an example of a patient's lower lid intruding on the maps on the lower and on the front and back elevation. You can see the front elevation is reduced to 7.58 and giving us a yellow flag, and the back is reduced to 7.07, giving us a red flag. Again, these maps should be redone because you cannot determine that this final D value is indeed white and normal when you have a reduced capture diameter or an abnormal QS. We have another example now of a patient's upper lid that's significantly intruding. We're getting very small capture diameters here, 2.87 and 2.74. Again, these maps are unreliable. We can also see the QS value is red and is telling us the patient's blinking. Therefore, looking at this final D value as red and 3.65, you cannot be relied upon, and this map must be remeasured. Now, looking at this 4-map refractive, we have a good QS value on the front and the back of the eye. They're white and okay. So this is a very excellent scan. This patient clearly has some abnormalities consistent with keratoconus. When we look at the corresponding CSP and we look at the quality measure here, we see unsteady fixation and a yellow flag. So despite the fact that the 4-map refractive was white and okay, we see here another example where other displays can be inadequate. And again, this CSP map should be redone to see if we can get better fixation. And if we drill down here, we can actually see the fixation problems with the 5th scan. And again, we want to go back and repeat all 5 of these scans so we can have a better quality map if we're going to design a lens based on that data. Here's one more example of a 4-map refractive map. We see again a very good QS value on the front, a very good QS value on the back of the eye. And if we go and take a look at the Scheimpflug image, we see here it's a very nice looking Scheimpflug image where we see a very black dense background. We see no light really intruding into this. And we see the edge detection is uniform on the back and on the front of the cornea. So very nice capture here. But we take a look at the BAD map on this good capture. We see here the final D is a 1.69. So this again is with a good capture. If we take this very same eye and repeat the scan, and now we get not such a great capture here. So we got some light contamination. Now, take a look at this BAD. The BAD itself does not look bad. We have a good quality assessment on the front and a good quality assessment on the back. But now when we go to the Scheimpflug image, we see here that the background is not dense black, it's light and gray. And this is from the light intrusion, the light that was left on in the room. And that's going to reduce the quality of the edge detection, and it's going to alter our ability to have a quality scan. If we take a look at the corresponding BAD map, look at the elevation of the same exact eye just a few seconds later due to the light contamination and the bad edge detection. So again, understanding the impact of either abnormal QS values or light contamination is really important to know that you are supplying reliable data, making good decisions on good data. Now, in addition to light contamination, fixation is also important. Here's an example of a 4-map refractive with good fixation. We see the front QS is okay in white, the back QS is okay in white. And if we look at the shine fluke images, again, we see all 25 look great. We see full exposure on the iris camera down below. If we go to the BAD map, again, here we see the BAD is 0.79. And again, we got a good reliable white QS value up top. Now, if we take the same eye a few seconds later, this is granted an extreme example of poor fixation, and I would hope that everyone would notice this and disregard this. But in any case, if we take a look here, we've got a red QS value on the front of the map, and we got a yellow QS on the back cornea. And again, this is the 4-map refractive. If we go forward and we take a look at the shine fluke images, we can see the variation in the tilt of the eye, the tilt of the crystalline lens and the iris. Again, the eye is moving during the scan, and that's the improper fixation. And the easiest place to tell is down below at the iris camera image. You can see that that patient is looking eccentrically. And what that translates to, when you look at the BAD map, it elevated the BAD value. While it didn't turn yellow, it elevated it quite significantly. So again, we have abnormal capture diameters, flagged red on the front, flagged red in the back. Even though the QS is white, we still know that this is a poor fixation and we can't rely upon this data. Now, what else can be affected? Well, we can even get more of a significant consequence to clinical decision making, and one example is in IOL calculations. If we take a look at this 4-map refractive, again, we got an excellent QS value on the front, an excellent QS value on the back. The maps look very good as far as capture size. Now, this is the same exact eye a few seconds later, where again, we see the patient's blinking. We get red QS on the front, red QS on the back. We can see this loss of data here in the white strip here. And if we take a look at the shine fluke images, we can see the changes in the tilt of the cornea and the iris plane. And if you look down below at the iris camera, you can see we captured a blink during that picture being taken. Now, what does that correspond to? Let's take a look if we calculate the IOL with both of those scans, remembering this is the same eye, just a few seconds apart. First, let's take a look at the K readings. Look at the difference between the K reading on the good capture, which is the one on here on the left, compared to the poor capture here on the right. The K reading is almost 2 diopters different, and what that represents, though, in the final outcome is the prediction for the IOL is 2.5 diopters different between the good scan, which predicts us to use a 17.5 diopter lens, and the poor scan, which is telling us to do a 20 diopter lens. That would be a 2.5 diopter surprise, making the patient really unhappy. So good scans result in great outcomes. And if you have good white OK values and good fixation, you're going to get great predictive outcomes. Now, what about toric IOLs? Well, the same thing happens. Here's an example of a good scan for a patient with a white QS on the front, a white QS on the back. We've got a little bit of data missing here down below, but that's probably not significant enough. We'll take a look to see how that looks on the next scan of the same eye a few seconds later. The patient was clearly blinking. We've got red QS on the front, red QS on the back. Now we have a lot more data missing. In fact, we're intruding in again to that final 7mm ring here, and we've lost significant inferior data. Now let's take a look at what happens when we look at the shine fluke image. We see clearly the top 10 images are all really blocked by the lid. In fact, we don't get good images till around image 13. So about half the data is poor on this patient's eye. And this will also result in a bad calculation for the IOL. Again, on the left-hand side, we have the good capture. And on the right-hand side, we have the poor capture. Take a look at the effect it has on K readings. The flat K is actually made 2 diopters flatter, and the steep K is made 2 diopters steeper, resulting in an IOL calculation or a difference in astigmatism assessment. And again, remember, we're doing a toric IOL of 1.1 diopters on the good scan and 5.5 on the terrible scan. a 4 diopter difference in calculation, really resulting in us choosing the wrong toric IOL. Now, what about contact lenses? Well, again, good scans equal good lens design, bad scans equal bad lens design. Here I have an example of a right eye, 2 scans taken, again, just a few seconds apart. When you look at the sagittal maps and you look at the tangential maps, there really isn't a big difference between these 2 maps. So I'm actually pretty happy with these 2 scans. But let's take a look at the scleral data. So here's the scleral data from the 2 scans of the same eye just seconds apart. On the left-hand side, you can see here, we only captured 78% of the 15 millimeter data zone. In fact, what we lost was a lot of the superior data and a lot of the inferior data. We've got great coverage from lateral, from temporal to nasal, great coverage, but we've got lots of poor coverage in the vertical meridian. When you look at the elevation data on the sclera and on the cornea, it doesn't look a lot different until we go and design the lens. Once we design the lens and manufacture it, look at the difference in the fit of this first lens. The bad data on the left-hand side here resulted in a lens that had a bubble that could not be resolved, and the patient couldn't leave with this lens. And on the left-hand side, the lens that was designed from that data was a perfectly fit lens. And again, the patient was able to see well, able to leave with that lens. And that's really our goal with our contact lens patients, especially on these specialty fits. You want to be able to create a lens that the patient can leave with the initial lens on the very first visit. Now, what about designing corneal GPs? Well, here's a patient that was referred to me that had a corneal GP and was complaining of discomfort and the lens getting dislodged quite often. And if you look at this picture on the left-hand side here, this lens was designed from topography data, but it was a placido design, and it only had about 6 millimeters of data that was actually measured, and the rest of the data was extrapolated. And the end result in this patient was a significant amount of edge lift. You can see the fluorescein pattern. You can actually see the edge of the lens here. There's so much edge lift, the fluorescein wouldn't even fill in that space down below. And this results in the patient being aware of the lens. It's physically uncomfortable, and the lens would move quite a bit. If we take that same cornea and take a Pentacam scan and get full corneal data, redesign that lens, you can see how beautiful this lens fits. It's perfectly centered, very minimal edge lift, and the patient was very comfortable and had wonderful vision. So again, the design of the edge of a contact lens is really important, that we don't use extrapolated data, that we use real data. It just increases our chances of a first fit success. This is an ortho-K patient that was referred to me. On the left is their right eye, on the right is their left eye. On the left-hand side here, you see the patient came into me wearing their lenses in the morning because they told me that their lenses were painful to remove. So I said, you know what, come in wearing the lenses first thing in the morning. So this was an 8 a.m. visit. Patient had their lenses in, and you can see this lens is not moving at all. It's adhered to the cornea. And on the left eye, the lens was moving just a little bit, but you can see these bubbles trapped in the return zone here. And this is, again, resulting in a lot of discomfort when the patient removes the lens. In fact, if you take a look, when we remove the lenses, this is what the patient's cornea looked like. You can see this staining pattern where, again, the lens was so tight, it was digging into the epithelium, and we have some dimple veil right here on this nasal portion. In the fellow left eye, all we have is a whole bunch of dimple veil all over the return zone, and the whole center of the cornea had the diffuse SPK. And that's why the patient was complaining of discomfort upon lens removal and also blurred vision throughout the morning. So this patient did really well. We washed him out. We made him wear soft toric lenses for a few weeks, and we refit them with a tomography full corneal design, and this is what their lens looked like on their eye. Again, good movement, no discomfort upon removal, and a nice clean cornea. So the moral of the story is good data produces good outcomes, whether you're designing contact lenses, screening patients for refractive surgery, or calculating IOLs for cataract surgery. So I'd like to thank you tonight for coming to this webinar. I want to thank Michelle Stoecklin for being my co-presenter. And you can contact me at btullo@oculususa.com or our clinical application team at application@oculususa.com. So I'm going to ask Carver, do we have any questions tonight?
It sounds like Carver may be having some technical issues at this moment. I'll go ahead and ask the first question. I often see patients with dry eyes and they end up with fixation errors. Is there a solution for this?
So patients with dry eye, so one of the benefits of elevation tomography and Pentacam specifically is that it is tear film independent, but patients with dry eye can have a difficult time keeping their eyes open. And even though the Pentacam scan only takes 1 to 2 seconds, depending on what type of scan you're doing, that could be difficult for a patient with significant dry eye to do, especially to do repeatedly over and over. And maybe the Pentacam wasn't even the first test performed on them, so it can be challenging. So what I find in patients who have a difficult time keeping their eyes open, I will often put a drop of anesthetic in their eye, a drop of proparacaine or tetracaine, and wait a minute or so, and that will usually make the patient comfortable enough where they can now cooperate and do an excellent exam.
Alrighty, so the next question I have for you, since we've seen so many of those images on contact lens patients with fluorescein, can you have fluorescein in the eye before doing a Pentacam scan?
Fluorescein is problematic in the Pentacam. Number one, because it causes reflection. The Scheimpflug image will be altered by the presence of fluorescein in the tear film. So we always recommend taking the Pentacam scans before any application of fluorescein. Afterwards, once you're done with your scans and you're sure you've got good quality scans, and my technicians in my clinic, I have 3 technicians, 2 of them are excellent, and I never have to worry. One of them still has some problems. I always make sure that I get to review the scans before a patient leaves the office. We never want to have a patient have to come back for rescanning, whether it's a contact lens design or any other reason why we're doing Pentacam imaging. It's really important that we get good data, but fluorescein should not be put in the eye before a Pentacam scan. And if it is, you should wait at least 15 minutes, and I would put artificial tears in every minute or so just to reduce the fluorescein in the eye, because that will reduce significantly the ability to edge detect also.
On a similar note, you mentioned that the Pentacam is very accurate. However, sometimes not all of the measurements that we take are useful, even though the Pentacam is measuring accurately, such as a scan on a patient whose contacts have left an impression on their eye. How long do you need to have a patient that's been wearing contact lenses for a long time wash out? And does that depend upon the type of contact lens?
Well, that's exactly the answer to the question. And first, we can talk about a category of lenses, soft lenses. We found in refractive surgery that soft daily wear disposable lenses, patients can be out of them for as little as 24 hours and have excellent, accurate scans. And other patients wearing different soft lenses like soft toric lenses or soft extended wear and sleeping with lenses, they can sometimes need to be out of the lenses as much as a week or more. And what we recommend is doing sequential scans. If you can get 2 scans in a row that are 24 hours apart, that are not significantly different, I think you'd be comfortable with stability. But if a patient is wearing some extraordinary lenses like a gas permeable lenses, it may take a few weeks, several weeks or months even to get their corneas to a stable portion. And for patients who sleep with lenses or wear gas permeable lenses, I think the best rule of thumb is to see them weekly until you get consecutive scans, that are within normal limits. And I use to compare 2 scans to do that, to see if I have any significant changes in both my tangential maps and my elevation maps, just to make sure, again, that the corneas are back to their normal state. But contact lenses can have significant effects, and so can scleral lenses. Even though they're not touching the cornea, they can have significant effects also. I usually like to have scleral lenses out of their eyes for at least a day if I'm going to take measurements of their cornea, especially if I'm considering IOL calculations or anything that's very crucial that can determine the outcome of a surgical procedure.
What a great answer, Bill. I wanted to follow up on that just a little bit more. Say you aren't looking at this patient in terms of performing surgery, but say just screening for keratoconus. Would your guidelines there be a bit more flexible?
Yeah, I think screening for keratoconus, I think if you get a normal, so the BAD screener is for abnormal eyes, keratoconus being one of the abnormalities that the Bell-Ambrosio enhanced ectasia display screens for. And I think if you measure an eye that just got out of their contact lens wear and it measures normal BAD on the final BAD measurement, I think you can be safe that even if it's an elevated number, if it's white and normal, I think you know that that patient is likely not to have an abnormal cornea. On the other hand, if you've just taken out a contact lens, maybe right prior to the examination, and you get a yellow or red final D, I think that's could certainly be a false positive that you would not want to rely upon. And again, depending on what kind of lens they were wearing would depend when I would have them back to remeasure. And then unlike a surgical procedure, I think my tolerance for time would be a little bit less. So again, on a soft lens, maybe 24 to 48 hours out of the soft lens. On a rigid gas permeable lens or a hybrid lens, maybe a week out of that lens would be necessary to get a reliable screening measurement on the Bell-Ambrosio enhanced ectasia display. So yes, I would be a little more, I wouldn't need to take quite as much time as if I was measuring for an IOL calculation or determining a surgical outcome.
Perfect. Thank you, Bill. All right, we're going to get into the difficult questions, the hard ones that'll really throw you for a loop.
This will be for Michelle then.
What effect do the lids have on the shape of the globe and the cornea?
Wow, that is a hard question. And the answer is yes, they have an effect. And everyone's lid's tension is different, and the angle that the lid will push on the cornea and the sclera is different. So it does have an effect on the eye, and we know that when we pull lids away that the architecture of the cornea does change slightly, some patients more than others, and the architecture of the sclera can change also. So it really depends on the age of the patient, the tightness of the lids, and the angle the lids will press on the cornea. So it's really important when you are pulling lids out of the way for these imaging is that you don't put any pressure on the globe. That is really what can vary the map significantly. So training your technicians how to lift lids or lower lids in the lower lid is really important, that they are not simultaneously pressing on the globe. And we have a device called the lid stick that I think is very handy and useful, and an easy way of taking lids out of the way of the scan without applying any undue force on the globe or the cornea.
I'm going to add to that where, depending on patient facial anatomy, in positioning the cornea at the widest aperture point of the lids, because I'll find even when scanning kids, for some reason they position their head oddly, and the headrest and their cornea is completely shoved into the corner of their eye. So being able to look at your iris image and kind of see in that live window where is the cornea sitting, or the iris I should say, and get it to the widest aperture point that you can naturally as well.
That's great. Thank you, Michelle. That's a really good technique for anyone looking to improve their scan tips. I do have one final question for you both, the hardest of the hardest. How does the time of day affect the scans? Because the human body is not a static thing throughout the day.
That is true. There is diurnal variations, and particularly in pachymetry values or corneal thickness measurements. And particularly in eyes with pathologies like Fuchs dystrophy, where corneal thicknesses throughout the day can vary quite a bit. In normal eyes, though, the variation is quite minor, typically less than 5 microns. So it typically isn't very significant, and K readings typically don't change very much on normal eyes, again, from morning to afternoon to evening. But it's the pathological eyes where you will see more variations. Patients with glaucoma, high pressure in their eye, or variable pressure in their eye, patients with abnormal corneas, as I mentioned, Fuchs dystrophy, or even very, very thin corneas, can vary more with IOP changes that normally do vary from morning to afternoon to evening. So I guess the answer to the question is, for normal eyes, I think it's clinically insignificant, any changes that do occur time of day. But I think with abnormal eyes, you'll definitely can see differences in scans from morning to afternoon to evening. And I have some of my patients, particularly my Fuchs patients, come in at either first in the morning or last in the day, so I can actually look at those variations because the symptoms of the patients usually follow those variations also. I hope that was the hardest question, Carver.
It was. In fact, that was our final question for the evening. So I wanted to go ahead and thank you both so much for your presentation tonight.
Yeah, thank you.
Thank you, Carver. Thank you for hosting.
And on behalf of Oculus, I wanted to thank everyone in attendance tonight. There will be a recording of this webcast sent out to everyone. So I hope you keep an eye out for that. And again, if you have any questions at all, don't hesitate to reach out to either the clinical application department or Bill. And we really want to make sure that you are having the best scans possible.
Thank you very much and have a good night.